endocrine system, essential hormones. In this part of lecture, we are going to learn the main characteristics of the thyroid and adrenal cortex hormones. And we begin with thyroid hormones. Thyroid gland is located at the anterior side of the neck. It is of the butterfly-like shape with two lobes. The main hormones of this gland that exactly are called thyroid hormones are thyroxine and triiodothyronine, or simply T3 and T4. These hormones are produced by the follicular cells of thyroid gland. Also, there are perifollicular cells that produce calcitonin, hormone that regulates the calcium blood level. This hormone is going to be considered separately among the hormones that are involved into calcium blood level regulation. And we are going to concentrate on the classical thyroid hormones. Let's recall their structure. As you can see, they are almost identical. This is tetraiodothyronine, thyroxine, T4, and beneath there is triiodothyronine, T3. And there is only one difference in one iodine atom that is absent in triiodothyronine. But somehow triiodothyronine is much more potent as compared to thyroxine. First, let's recall the feedback regulation of the thyroid secretion. Hypothalamus produces TRH, thyrotropin releasing hormone. This hormone comes to the anterior pituitary and stimulates the cells of anterior pituitary to produce thyroid stimulating hormone, TSH. Then TSH is released into blood, comes to the thyroid gland, binds to the receptor of the follicular cells and stimulates production of T3, T4, secretion of T3 and T4. As well, it stimulates the growth of the gland itself. Just the normal TSH level simply contributes to normal size of the thyroid gland. T3 and T4 secreted into blood control the level of TRH and TSH by the feedback, and this feedback is negative because it produces inhibition of secretion of TSH and TRH. So normal level of T3 and T4 keeps TSH and TRH normal level. If T3 and T4 become higher and higher, they start to inhibit stronger and stronger, and TRH and TSH levels decrease. But in case of deficiency of T3 and T4, this feedback inhibition becomes less than usual, therefore levels of TSH and TRH become higher. And finally, it results in normal secretion of T3 and T4. This is a classical negative feedback control. Let's recall also the mechanism of these hormones' action. They are based on the tyrosine amino acid, but nevertheless they are lipid soluble. Therefore, they act through the intracellular receptors. As they are lipid soluble, the first stage of their action is diffusion to the cell. Simply through the membrane, they diffuse inside. And if it's T4, when it goes inside the cell, it undergoes deiodination. One iodine atom is removed from the molecule, it simply becomes converted to T3. Then next stage is binding to intracellular receptors which are located inside the nuclei. These are nuclear receptors already attached to the DNA inside the nucleus. These thyroid hormone receptors are usually combined with a so-called retinoid X receptor. They both can stimulate, when activated, the so-called thyroid hormone response element, the portion of DNA that responds by transcription under binding of hormone to the receptor, nuclear receptors. So next stage is the genes transcription and formation of mRNA. Corresponding component of part of DNA is converted to mRNA, and therefore specific proteins are produced, and it's a final stage of thyroid hormone action, production of numerous new proteins, which takes a long time, therefore It's a slow-acting type of hormones. And these new proteins can be structural, then can be enzymes. Therefore, there are a number of structural, morphological effects and number of metabolic effects. Some of them are listed here, but we're going to consider effects separately. But you can notice numerous metabolic effects, changes of cell metabolism, then big group of cardiovascular effects, all stimulatory, and number of effects that develop due to formation of new structural protein, and general growth is based on this, and specific type of growth and development of the central nervous system. But first, let's come back to the structure and functioning of the thyroid gland. Let's observe a little bit of histology. The thyroid follicles, the thyroid gland, consists of numerous follicles. You see they are mentioned here with letter F. And now it's enlarged follicle. You see peripheral layer of follicular cells. And inside, shown in pink, this is colloid. Colloid that contains thyroid hormones. Exactly within this colloid, many reactions occur that result in formation of hormones. And this is the place of their storage. Now we see the enlarged colloid. Do not forget that these are only cross-sections with dimensional structure, and really follicles are a three-dimensional structure, egg-like shaped and with perimeter covered by follicular cells. Let's observe the general mechanism of production and storage of thyroid hormones, first as a text, then as a scheme. First, to produce thyroid hormones, it's necessary to get from blood the iodine. Iodine should be present as ion in blood, so that it is possible to form thyroid hormones. And these iodine ions are actively transported through follicular cells into colloid, where first iodine ions should be converted to iodine molecules, so to use the atoms. And they become attached to tyrosine amino acid within the thyroglobulin protein. And as a result, two types of compounds are formed, monoiodotyrosine and diiodotyrosine. Then on the basis of this, T3 and T4 can be produced by combination. There is combination of these components. All occurs within the thyroglobulin, within the colloid. Then when TSH hormone comes, it binds to the receptors of the follicular cells and stimulates secretion of the thyroid hormones. How it occurs? Follicular cells produce endocytosis of portions of the colloid from inside the follicle, and inside the cells, free T3 and T4 hormones are retrieved, and then they are secreted outside into blood. Let's observe as a scheme. It may be easier for understanding. Let's follow. First, ion of iodine should be taken inside the colloid. Then, with the help of the enzyme peroxidase, iodine is formed as a molecular type and combined with thyroglobulin. And within this thyroglobulin, monoiodotyrosine and diiodotyrosine are formed. Then combination of mono and diiodotyrosine produces triiodothyronine, or T3, and combination of two diiodotyrosines creates tetraiodotyrosine, or simply thyroxine. Both hormones remain attached within the thyroglobulin. But when TSH appears, and it binds from outside, TSH is the peptide hormone that binds from side of blood, it binds to 7-TMS receptors on the surface of follicular cells. And it results in stimulation of secretion. So the cells endocytize the components of the colloid, and inside the cells, free hormones are produced and released outside into blood. As these hormones are lipid soluble, they should be transported in blood attached to carrier protein. Actually, this is thyroxine binding globulin. mostly to globulins. They become attached, and probably a little bit to albumins, because they are insoluble in blood plasma. They are not hydrophilic hormones. But then they can be released and pass through the membranes into target cells, where they bind to nuclear receptors and activate formation of numerous proteins. And now we come to the most complex part: action, effects of thyroid hormones. These effects are so numerous that to bring into system, we need to divide them at least into two separate groups. Effects that are achieved on the level of metabolic changes within the cell, metabolic and cellular effects, and resulting effects on the level of the tissues, organs, and the body as a whole. So let's begin with metabolic effects. I prefer to follow the general sequence of consideration of the effects on metabolism, with proteins, then effect on fat metabolism, and then effects on carbohydrate, and any other effects later. So first, effect for protein. And here, instead of simply mentioning what is the effect of general on proteins, here I must to provide the basis for one brightest effect of the thyroid hormone, and this is formation of one specific protein, sodium potassium ATPase. Of course, it can be also called sodium potassium pump. This is widespread protein molecule inserted into membrane of many cells throughout the body. And each such molecule pumps sodium and potassium both against their concentration gradient. Sodium is transferred into cell, sodium is transported out of cell, while potassium is transported into cell, both against gradient, so it's necessary to use energy for this. And ATP is broken down for this purpose, so the pump also is called ATPase, the enzyme that splits ATP. And so the first brightest effect of the thyroid hormones, at least partially, can be explained by this, because generally the thyroid hormones increase the level of all metabolic processes and energy expenditure in the body. And it's clear that, at least from this synthesis of pump, the energy expenditure increases proportionally to the number of new pumps. And then we can understand why oxygen consumption increases. So this effect on the cellular level and similar effect will be on the level of the body as a whole. Greater energy and oxygen consumption. Then we can simply mention the general stimulation of many other proteins synthesis. These proteins can be structural proteins for growth, for formation of new cells, for proliferation, for specific changes inside the cell. Then it can be enzyme that changes some metabolic processes, and it's responsible for some next effects. Lipolysis. For fats, there is breakdown of lipids, so that free fatty acids are formed. And you know that fatty acids are the most calories-containing substances. The fats generally give per each gram 9 kilocalories, while the other substances just 4 kilocalories. So lipids, free fatty acids, are good source of energy. But of course it needs also oxygen usage, but oxygen is also used as well. Then for carbohydrates, this is also breakdown of complex glycogen molecules, so that more and more glucose is released from the liver. So glycogenolysis increases glucose level. And this effect mostly is achieved by glycogenolysis, but little bit thyroid hormones activate the process of new glucose formation, which is gluconeogenesis, formation from non-carbohydrate sources such as amino acids, for example. But mostly the glucose elevation is achieved through glycogenolysis. And all these processes bring glucose to higher level, and secondarily this glucose immediately influences the beta cells of the Langerhans islets inside the pancreas, and beta cells respond to glucose increase by secretion of insulin. So not thyroid hormones stimulate insulin secretion, but thyroid hormones increase level of glucose, and this glucose immediately produces stimulation of the insulin secretion. But the thyroid hormones make some obstacles for insulin action. They prevent quick decrease of glucose that can be achieved by insulin. And thyroid hormones, as many other hormones that operate against insulin and they increase glucose, they produce some effects that decrease activity of insulin. For example, they may increase insulinase activity. This is a liver enzyme that destroys insulin. So the lifespan of insulin molecule is limited, and when insulin is split by insulinase, its action is stopped. So by thyroid hormones action, we have a certain decrease of lifespan of insulin molecule, so it decreases effect. Also, insulin receptors sensitivity is decreased somehow by thyroid hormones action. All this and maybe some other points are responsible for inability of insulin to decrease glucose back to decreased level quickly. Then there is one specific action on beta-adrenergic receptors sensitivity, the so-called permissive effect. Thyroid hormones are lipid-soluble molecules that somehow modify the sensitivity of 7-TMS beta-adrenergic receptors in the membranes. And they become more sensitive to their ligands, which are catecholamines, adrenaline and noradrenaline, mostly adrenaline, of course, for beta receptors. And presence of thyroid hormones is necessary to provide normal sensitivity of these receptors. So themselves hormones do not bind to these receptors, but presence of thyroid hormones in normal amount makes sensitivity of receptors normal, so that response to catecholamines is normal. Excess of thyroid hormones proportionally increases sensitivity, and the same level of catecholamines produces stronger effect on the receptor. And correspondingly, decreased level of thyroid hormones produces decreased sensitivity, and again, the same level of catecholamines makes smaller effect on beta-adrenergic receptors. So it looks like thyroid hormones permit catecholamines to produce the effect on beta-adrenergic receptors. That's why we call this permissive effect. And also, thyroid hormones are responsible for stimulation of formation and excretion of cholesterol. Maybe here it's more important that excretion is stimulated by thyroid hormones. So cholesterol does not become high, does not become accumulated in the body, and easily is excreted. These are cellular effects. Now let's move to the physiological effects on the level of organs and the body as a whole. And look, oxygen consumption increases, and oxygen normally is used for oxidation, and a main substrate that we oxidate to get energy are fatty acids and glucose, and both lipolysis and glycogenolysis provide both these substrates. So fatty acids oxidated and glucose oxidated give us a lot of energy. So our energy production increases, and we spend more energy. And these energy expenditures increase can be named by higher metabolic rate, and especially the basal metabolic rate. BMR stands for basal metabolic rate, which is not related to real activity of the body, because clearly the one person that is at rest and person which is performing the physical activity, their difference is explained by the reasons. But even in the absence of physical activity, simply basal metabolic rate, not related to specific elevations of activity, becomes higher under thyroid hormones action. And as energy expenditure results in conversion of energy from different types finally into one and the same type, heat. So it makes higher heat production, and so it's called calorigenic action. It contributes to maintaining body temperature. And of course, the physiological level of hormones contributes to normal body temperature, while excess of deficiency of hormones may change temperature in the corresponding site. So maybe it's number one simplest effect of the thyroid hormones to increase metabolic rate, and basal metabolic rate in particular. Then, number of effects come from the general stimulation of protein synthesis. And maybe number one consequence is the specific growth and development of the central nervous system. This process, of course, occurs mostly early in life, mostly during the fetal life and first weeks after birth. And exactly at this time, the brain and central nervous system develops most intensely. And therefore, exactly during this period, the presence of thyroid hormones is of high importance. And deficiency, exactly during this time, deficiency of thyroid hormones will have very bad, irreparable consequences. So, central nervous system growth and development stays separately from other types of stimulation of protein synthesis because it's related to specific age only. Bone formation and maturation takes longer time, not only perinatal period, it goes until puberty and even later. Also, thyroid hormones are necessary because bone does not consist only of the inorganic components, but it contains proteins and which provide normal maturation and formation of the bones. And what is important for any age, tissue regeneration, restoration after any damage, requires protein synthesis stimulation. Without this, it's not possible to produce normal regeneration. So thyroid hormones also are involved into this process. Then, next set of effects is all based on a beta-adrenergic receptor sensitivity increase. And they even are called sympathetic effects because the beta receptors are responsible for sympathetic effects of catecholamines and coincide practically with effects of the sympathetic nerves stimulation. And it includes the heart rate and contractility elevation because heart contains exactly beta-1 adrenergic receptors and their high effect contributes to maintaining of normal heart rate and heart contractility. And when heart rate and contractility increases, cardiac output and blood pressure all increase proportionally. Then respiration rate also is stimulated by sympathetic system, and central nervous system excitability is stimulated, and process of perspiration, sweating, is controlled by sympathetic system, and therefore all these effects become contributed by thyroid hormones. And excess of hormones may increase all these effects and deficiency may decrease all these effects. All this due to permissive effects. And then there is slight diuretic action, predominantly because of filtration over reabsorption in kidney. Partially it's because of the vascular effects with high filtration. So these are physiological effects of the thyroid hormones. Now let's consider exactly what happens in case of deficiency of thyroid hormones in early age. This results in such a state which is called cretinism. Again, thyroid hormones are necessary to stimulate protein synthesis, which is underlying process for any development, and particularly development of the central nervous system. And most essential thyroid hormones are during perinatal period. Peri is around, so slightly before birth, last parts of pregnancy, and first months after birth. And exactly during this time, the processes of brain formation go very intensively. These hormones are necessary for formation of new nerve endings, nerve terminals, formation of synapses, establishment of connections between neurons, growth of dendrites that provide input of information, dendritic spines, contacts between cells, then myelin sheath formation. All these processes, and even more and more, all they require protein formation. And only with these processes the central nervous system may grow and develop, and the brain may establish new and new layers, establish connections, numerous connections between neurons, so that neural network is formed. And network exactly is what brain is doing for its functioning. So absence of thyroid hormones during all this period results in a poorly developed nervous system, and mental retardation, called cretinism, remains forever, and mentally they will never become normal. Also, there are some other changes. For example, in this picture you may observe practically a specific face expression, but face expression itself is not enough, of course, for diagnosis. But here you can see one more sign, too large tongue. It happens because the growth of internal organs is not so much impaired as growth of the bones and generally height of the body. Therefore, there is disproportional growth of internal organs as compared to bones, and sometimes, for example, tongue becomes too large so that it obstructs the swallowing and makes problems for breathing of children. Also, what should be mentioned, that bones also require hormones for their growth, and if a person with cretinism manages to live to adult age, they remain very short. They become like dwarfs, but dwarfs do not have any problems with their brain development, if you remember about the growth hormone deficiency. But here they become, with cretinism, with poorly developed central nervous system, and as well they are shorter than normal. Their bones are much shorter, their growth is impaired, and usually they have oversize because of excessive, as compared to bones, growth of the soft tissues. Now let's consider general symptoms of excessive and insufficient secretion of thyroid hormones that develops mostly in adult age, without consideration of cretinism specifically. So hyperthyroidism and hypothyroidism, excess and deficiency. Actually, we will consider in comparison too, because mostly it's easily deduced from normal action of hormones, and mostly it's exactly opposite. Maybe first, most bright effect is increase in metabolic rate. So while thyroid hormones are necessary to maintain normal metabolic rate, hyperthyroidism is accompanied by higher than normal metabolic rate. And due to such a high level of metabolism, weight loss occurs regardless of maybe even higher requirement of people in food. Oppositely, people with deficiency of hormones have decreased metabolic rate, all metabolism is slowed down, and they usually have weight gain. Then, heat production is increased. It's simply connected to metabolic rate. When metabolic rate increases, more energy is used and more heat is produced as a result. And therefore, people have problem when it becomes hot outside. They hardly can tolerate this heat because they have increased heat production initially. And oppositely, hypothyroidism is accompanied by decreased heat production. These people feel cold even at normal room temperature, and correspondingly, they cannot tolerate additional cold outside. Then, if we switch to children and teenagers, accelerated growth due to bone growth faster in children, and impaired growth in children depending on level of thyroid hormones. Growth is accelerated in excess of thyroid hormones, and impaired decreased growth in hypothyroidism case. Then, cardiac output due to permissive effect, due to higher sensitivity of beta-adrenergic receptors. Tachycardia is characteristic for hyperthyroidism, and higher cardiac output. And opposite for hypothyroidism, decreased cardiac output, and maybe bradycardia is more characteristic. Of course, it's necessary to keep in mind that both description refers to really pronounced, expressed cases, because sometimes mild types exist where not necessarily all the symptoms are present, but for classical, untreated, expressed cases of hyper and hypothyroidism, we consider these symptoms. Then hyperventilation due to excessive stimulation of respiratory centered by sympathetic system for excessive hormones, and hypoventilation for deficiency. Then increased sweating. If you remember, sweating is also part of the sympathetic effects, and increased sweating is characteristic for hyperthyroidism, and absence of sweating for decreased hormones level. Then increased appetite. Because of high metabolic rate, the people need more and more food, but nevertheless they have weight loss because of intensive metabolism. They have also increased intestinal motor activity up to even diarrhea. And hypothyroidism, people have decreased appetite and have tendency to constipation with decreased motor activity of the intestines. Then nervous system. Stimulation of nervous system excitability by excessive hormones results in anxiety, irritability, increased reflexes, tremor of muscles, some sleeplessness is possible as well. For hypothyroidism, slowed reflexes, is characteristic apathy, mental retardation. It doesn't mean that it's retardation like in cretinism, no, but their processes, mental processes are slowed down, and they have no much interest for quick thinking and quick finding the answers for, and so on. Apathy, absence of interest to the surrounding. It's characteristic for hypothyroidism. Then, specific feature of appearance of patients with hyperthyroidism is exophthalmos. Exo means outside. So eyeballs are often bulged outside, which is gives them very characteristic appearance. Explanation of this will be followed in the next slide. And for hypothyroidism, people often have drooping eyelids, and their eyeballs are deeply located in the sockets, and eyelids are coming down to above the eyes. And often they have the edema of subcutaneous tissue that is called myxedema, which is like mucus edema. Also, it is due to specific changes of metabolism in the subcutaneous tissues, also considered next time. And until now, almost everything was exactly opposite. And now there can be one and the same symptom, goiter. Goiter means enlarged thyroid gland, which is clearly visible on the surface of neck. And in both cases, it can be present. And it's necessary to explain why it's possible in both cases, regardless of too high or too low level of hormones. But first, let's observe the appearance of patients with their characteristic symptoms. First case, I can observe here exophthalmos. Not necessarily every patient may have this exophthalmos, but each of 3 patients on average suffers from this. This results from swelling of the adipose tissue behind the eyeballs, retroorbital adipose tissue and muscles, eyeball muscles. And this swelling pushes the eyeballs forward, which creates discomfort and characteristic appearance, but in some cases it may create even damages to the optic nerve, which is stretched too much, and it can somehow damage the visual system. So it's a serious symptom. Then, this is appearance characteristic for severe type of hypothyroidism, when metabolism is changed in subcutaneous tissues so that such substances as glycosaminoglycans are formed in the connective tissue, in the interstitium. And these substances are highly water attracting, and water accumulation occurs there, and puffiness of the skin all around occurs, but here characteristic puffiness can be visible in the face. And this has exactly name myxedema, mucus edema, because of accumulation of these polymeric molecules in the subcutaneous tissues. And now let's consider why goiter develops. Goiter is enlargement of the gland itself. And perhaps you remember that TSH, thyroid stimulating hormone, may create this because it stimulates not only secretion of hormones, but also it stimulates the growth. Normal TSH level just contributes to normal size of the gland, but excessive TSH may produce this. But not always it's exactly TSH responsible. Let's observe. First, hyperthyroidism. There exist few types for hyperthyroidism, but most widespread is this named Graves' disease. Graves' disease and autoimmune type of pathology. And this autoimmune disease is accompanied by production of antibodies, pathological antibodies, against own receptors of TSH. So the follicular cells have receptors on their surface, 17-MS receptors for TSH. And somehow the immune system starts to produce pathologically antibodies against these receptors. But when antibodies bind to these receptors, they mimic action of TSH because receptors cannot differentiate. Something specifically binds to these receptors. Normally, this is TSH itself. But they cannot differentiate, is it TSH or something other. If it binds specifically, so it acts similarly to TSH itself. So now this is normal scheme of regulation. Now let's change. These antibodies to TSH receptors constantly bind in high amount to the receptors of the follicular cells in the thyroid gland. And they produce overstimulation, and gland grows too large and produces too much T3 and T4. Then it results in goiter, excessive growth of the gland. Then T3 and T4, due to negative feedback, produce very strong inhibition of both TRH and TSH. But itself it doesn't help, because antibodies do not become inhibited anyway by this inhibition. And antibodies to TSH receptors continuously bind to receptors and produce excessive growth and excessive production of hormones, because the antibodies are uncontrolled. By the way, even swelling of retroorbital tissues and muscles is also explained by attacks by antibodies to these tissues. Different, not to TSH receptors, but it's general autoimmune process. And so that results in exophthalmos. So we can see that in case of Graves' disease, hyperthyroidism, T3 and T4 levels are higher than normal, increased, but TSH and TRH are greatly decreased. So let's shift to the hypothyroidism. In this case, mostly it's because of thyroid pathology, damage of follicular cell initially, so that they cannot produce. By some chemicals it happened, by other different reasons sometimes unknown. The follicular cells are damaged. Or follicular cells can be even normal, but iodine is in deficit. And deficiency of iodine does not allow to produce normal hormones. So in this case, thyroid gland has low level of T3 and T4 because of two possible reasons. And it produces decrease of negative feedback inhibition. And TRH and TSH increase because of absence of inhibition. Excess of TSH overstimulates the gland and produces only stimulation of growth, because damaged cell cannot produce T3 and T4. They just grow but do not produce T3, T4. Or if even cells are not damaged but iodine is deficient, so there is no way to increase production of hormones due to absence of iodine. So stimulation of growth occurs only instead of stimulation of secretion and growth. And so we can see that goiter develops due to excess of TSH here. So if we measure blood content of hormones, T3 and T4 are decreased, but TSH and TRH are increased as compared to norm. But in both cases, you see, to the hypothyroidism, Graves' disease, it's because of overstimulation of growth by antibodies to TSH receptors that operate similarly to TSH itself. And for hypothyroidism, the right side picture, there is excess of TSH itself that overstimulates growth of the thyroid gland, so that goiter develops. And it can be much higher. I didn't take the most scaring pictures. These are less scaring, but the gland itself is well visible on the neck surface. Then we switch to adrenals. Adrenals are located nearby the kidney, and practically the both synonyms based on Latin roots like ad-ren. Ren is kidney in Latin, and the other term based on roots coming from Greek, epinephros, above kidney. Nephros is a kidney on Greek. So in both cases, this just describes the location, nearby or above kidney, adrenals. Adrenals are very important glands, and they produce numerous hormones because they consist of different layers of cells. Let's recall first this structure. Adrenal cortex, if we cut them, they look like triangles, as they are located on the above curved surface of the kidney. So first we can differentiate the adrenal cortex and adrenal medulla, the middle portion, which is not great in size. Cortex and medulla. Then if we make a little cross section of this to see all the layers enlarged, let's observe. It gives us all layers of cortex, because medulla is not subdivided, and cortex is subdivided into the 3 layers or zones. In Latin, it's named upper one, zona glomerulosa. In English, we say glomerulus zone. This is rather thin layer and most superficial layer. This zone produces aldosterone, or main mineral corticoid. Name mineral corticoid is useful to remember because in this case you easily remember that it influences the minerals, not metabolic processes. Then second layer, much thicker, middle layer, is fasciculate zone, or Latin zona fasciculata. So here the glucocorticoids are produced, and also named glucocorticoid is useful because it helps to memorize at least one great effect of cortisol and other corticosteroids to increase glucose level. Cortisol is the main representative, and much less amount is present here, corticosterone. And the third layer, most inner part, close to medulla, this is reticular zone, or zona reticularis. And this zone produces androgens, sex hormones, but androgens exactly, regardless of man or woman this body is. So you see 4 types of hormones are produced in the gland, as medulla produces catecholamines, collective name, and it includes adrenaline or epinephrine, and I hope now you understand. Epinephros, adrenaline, it's all the same, so they're synonyms. Epinephrine and adrenaline, or norepinephrine and noradrenaline. So these hormones are going to be considered separately in mostly in the themes of sympathetic nervous system, because the effects are similar to sympathetic nerves. They use the same receptors, the same mechanisms. Also, we are going to consider in detail them in the cardiovascular system. So now it's enough if we just mention that they have sympathetic effects, and rather soon we are going to study the autonomic nervous system and sympathetic division of it. And also you may remember that these cells are innervated by nervous system, not regulated by hormonal way, but exactly nerves, sympathetic nerves come from the spinal cord and come to the cells that produce in response of electrical stimulation by impulses. They produce, by then release of transmitter of course, then they produce secretion of hormones into blood. Now, let's have an idea about the synthetic pathways for all 3 types of hormones produced in the adrenal cortex. All 3 layers. Of course, it's not for memorizing, it's just for information. But what is important to understand that first stage is similar for all 3 layers of adrenal cortex. They all these hormones are produced from cholesterol. They are based on cholesterol. And the first stage is similar for all. Inside the mitochondria of cells, the cholesterol is converted to pregnenolone. Then there appears a little difference, and then, for example, reticular zone starts to produce differently, and glomerulus zone and fasciculate zone produce progesterone. And then, anyway, there is difference. Glomerulus zone produces aldosterone, fasciculate zone cortisol, and reticular zone produces dehydroepiandrosterone, which is converted to androstenedione, and finally in testis it becomes converted to testosterone. And one more thing to mention, that 3 zones are regulated differently: fasciculate zone and reticular zone, both these 2, second and third, are regulated by ACTH action, adrenocorticotropic hormone. And this hormone stimulates production of cortisol mostly, and a little bit it stimulates reticular zone androgens production. And ACTH does not stimulate secretion of aldosterone. But look at this, the first stage of conversion of cholesterol to pregnenolone requires presence of ACTH, because ACTH basically stimulates this process of conversion. I remind that ACTH acts through adenylate cyclase, cyclic AMP pathway, and as a result protein kinase A is activated, and due to action of phosphorylation produced by protein kinase A, cholesterol is converted to pregnenolone. It phosphorylates specific enzyme that can produce this conversion. So you may see that ACTH does not stimulate aldosterone production and not proportionally increases aldosterone production, but it is necessary to be present just for stimulation of this first stage for all the zones. And so it's not stimulating factor, but nevertheless it's somehow involved, just like condition for formation of aldosterone. ACTH should be present, which usually is present, of course. Now, let's consider in detail cortisol. First, let's recall feedback control of secretion. Cortisol is stimulated by ACTH, which is stimulated by CRH, but then cortisol, by negative feedback, inhibits both ACTH of pituitary and CRH of hypothalamus. So let's again. CRH, corticotropin releasing hormone, produced in hypothalamus. With blood it reaches the anterior pituitary and stimulates ACTH secretion. ACTH is secreted into blood, adrenocorticotropic hormone, reaches the adrenal cortex and stimulates mostly fasciculate zone cells to produce cortisol. And this cortisol, by negative feedback, inhibits both CRH and ACTH secretion. And all this system normally is well balanced, so all three hormones have their normal level. But excess of cortisol inhibits stronger corticotropin releasing hormone secretion and ACTH, and it decreases secretion, so cortisol comes back to normal. Deficiency of cortisol decreases inhibition, and CRH ACTH secretion increases, so that cortisol again increases back to normal level. So it's normal regulation with negative feedback. Secretion of cortisol is not even during the day. It has clearly expressed peak, which occurs approximately early in the morning, approximately 6 to 8 hours in the morning, AM. And hormone acts mostly during the day, because you remember that cortisol, as any lipid-soluble hormones operating through the intracellular receptors, has a long time of action. So effects develop slowly, and therefore by the midday they become more or less expressed and last for a day. And by the end of the day the level decreases to minimum. Action of glucocorticoids. Again, this is the most complex part. We need to consider all the effects, and these hormones do have many effects. And again, to bring them into system, we need to separate metabolic and cellular effect from physiological effects. Level of cells and molecules of metabolism and enzymes first to be considered, and then we consider what happens for the body as a whole. And here again, the same sequence, the same order: protein metabolism, then fat metabolism, then carbohydrate metabolism, then all the rest types of effects. And for protein metabolism, there is a big difference of glucocorticoids from thyroid hormones. They have many effects in common, many, but from the first there appears great difference. While thyroid hormones stimulate protein synthesis in many cells of the body, glucocorticoids stimulate protein catabolism in many cells and tissues of the body. Actually, you can say only about one exception: liver. In the liver there is no protein catabolism at all. But many tissues have catabolism, breakdown of proteins. And tissues that mostly involved into this are muscle, bone, connective tissue. Bone also is connective, but separately: skin, for example, and lymphoid tissue. And this protein catabolism means that from proteins, amino acids are released from these tissues into blood. So all this brings us amino acids. Then lipids also are broken down, so mostly it's catabolic action. And lipolysis gives release of the free fatty acid from stored in fat tissue, in stored triacylglycerols, free fatty acids. Then the third type of metabolism influence is on carbohydrates, and here this is gluconeogenesis. The process of gluconeogenesis, formation of new glucose, means that from non-carbohydrate sources, glucose is produced new. So stores of glycogen are not involved, not touched even. And glucose is formed from amino acids, and also glycerin portion of fatty acids is used. So glucose is produced as a new glucose, and we don't spend our stores of glycogen. Practically, it's the only one hormone that produces glucose elevation exclusively by gluconeogenesis. All the rest mostly stimulate glycogenolysis, or like thyroid hormones, a little bit add gluconeogenesis. But glucocorticoids do not spend at all glycogen. Then, if you see that glucose is elevated, I hope you can understand that this produces stimulation of insulin secretion. And here, great similarity you can observe with thyroid hormones and some other, that insulin activity is suppressed. Again, it can be insulinase activity stimulation in the liver, so insulin is destroyed earlier than usual, and its effect does not last long. And insulin receptor sensitivity is decreased, so that insulin cannot produce decrease of glucose very quickly and efficiently as normally it could do without action of glucocorticoid, without cortisol. Then there is also similarity to thyroid hormones, that there is a permissive effect with little difference. Not only beta adrenergic receptors become more sensitive, but generally adrenergic receptors. So not only beta effect, stimulation of beta receptors, but alpha receptors, which are responsible for vasoconstriction. And stabilization of lysosomal membranes. This effect is achieved on a cellular level. Membranes of lysosome normally do not allow the lysosomal digestive enzymes to escape to the cytoplasm, but under different damaging factors and unfavorable factors, it's possible to have instability of lysosomal membranes, and these enzymes may escape to the cytoplasm and may produce some harmful action on the cell. And glucocorticoids are able to stabilize these membranes and suppress escape of enzymes from lysosomes. And one more, inhibition of phospholipase A2. This is important effect, but it's going to be explained on the next slides in details. Now let's move to the effects on the level of the body as a whole. Here it's not so easy to deduce effects from the left side to the right side, because many effects develop independently on cellular effects, additional effects. But one effect depends. You see, glucose that is increased is exactly designed for central nervous system cells. So on the level of the body, glucose gives more nutrition to the cells of the brain and general central nervous system. Then central nervous system cells become more excitable, so excitability is stimulated. Partially it can be explained by sympathetic effects, partially it's a simple effect of cortisol. And sensitivity of analyzers also is increased, so that it helps to maintain normal sensitivity, our sensitivity to sounds, our sensitivity to odors, and so on. Analyzer sensitivity. So all this is responsible for faster operation by brain. Brain gets more information faster, can faster analyze this information due to high excitability, faster take decisions, which is very helpful for generally body resistance to many harmful factors. Adrenergic receptor sensitivity increased, permissive effect, produces number of sympathetic effects again. But here predominates vessel constriction in response to catecholamines. So the same level of catecholamines may produce normal effects when cortisol is normal, may produce excessive constriction when cortisol is too high, and may produce even no effect when cortisol is absent. So it's very serious and severe permissive effect. Permission can be given by cortisol to adrenergic receptors respond to the ligands catecholamines. So absence of glucocorticoids practically decreases to zero level effect of catecholamines on vessels. Then, due to this, due to vascular constriction and due to stimulation of the heart, blood pressure becomes higher. So cortisol contributes to maintaining of normal heart contractility and blood pressure. Then, on the basis of all listed above, you can see, this is anti-stress action. Resistance to harmful factors can be increased due to central nervous system faster operation, due to high level of cardiovascular system, due to high level of glucose that is available for central nervous system. All this non-specifically contributes to higher resistance of the body. And finally, last 2 points from the cellular effects, and not only this, but it's just main. a basis for application of synthetic glucocorticoids in medical practice. Mostly synthetic corticosteroids are used for their anti-inflammatory, anti-allergic, and immunosuppressive effects. Let's observe this anti-inflammatory action of glucocorticoids in more details. First, on the previous slide you saw that there is among cellular effects there is inhibition of phospholipase A2. Phospholipase is able to split phospholipids in the membrane, and exactly phospholipase A2 can split from membrane's phospholipid the substance arachidonic acid. In biochemistry, if you haven't yet studied, so you will study this, arachidonic acid is a source for numerous substances, biologically active substances, called prostaglandins and leukotrienes, and also thromboxanes. You can see next metabolizing of arachidonic acid can convert it into a number of substances. If under action of lipoxygenase, arachidonic acid is converted to leukotrienes. And if you see inflammation, bronchial constriction, high capillary permeability, vasoconstriction, the number of effects, they all are effects of inflammatory or allergic processes, leukotrienes. Then by the action of cyclooxygenase, arachidonic acid is converted to prostaglandins. Prostaglandins group includes many of them, and some of them are favorable for the body, but among prostaglandins there are many of harmful that involved into inflammatory and allergic processes, such as prostaglandin F2 alpha, thromboxane, and so on. And just imagine if phospholipase A2 is inhibited by cortisol, so there is no arachidonic acid at all to form any prostaglandins or leukotrienes. So it greatly suppresses the inflammatory processes. And phospholipase A2 inhibition prevents formation of leukotrienes, prostaglandins, thromboxanes. So it's just a part of effects, but it's number one, easily explained, that it's a great block of inflammatory substances formation. This is steroid anti-inflammatory substance, cortisol, compared to the non-steroid anti-inflammatory drugs, NSAID, you will study in pharmacology. This is a big group of substances widely used in the world, NSAID, and with main representative aspirin, but many others, paracetamol, ibuprofen, and many others you'll study in pharmacology. These substances block cyclooxygenase. They are inhibitors of cyclooxygenase, and therefore they block formation of prostaglandins. So, and anti-inflammatory action of glucocorticoids is more efficient as it also involves leukotrienes block of synthesis. But it's more serious type of medicines, more serious treatment, of course. Then let's go deeper into the role of cortisol and general glucocorticoids in stress. We mentioned that the cortisol increases stress resistance, and this is now well studied stress reaction of the body that results in hypersecretion of cortisol. The first to investigate this process was Hans Selye, Canadian scientist. Look, different types of stress, of very different type. Physical, which is mechanical damage and many others, emotional stress, chemicals such as hypoglycemia and others. They all may have different features, but have something in common. They all stimulate production in hypothalamus of the CRH, corticotropin releasing hormone. Level of this hormone becomes elevated, and it's not suppressed by negative feedback if it's stress reaction. And CRH is secreted into blood, into capillaries, then through portal vein goes into capillary system of the anterior pituitary. And here it stimulates secretion of ACTH, excess again in response, and excess of ACTH stimulates adrenal cortex to secrete excess of cortisol. And this cortisol, among generally many effects, increases availability of energy substrates, increases activity of the central nervous system and cardiovascular system. It inhibits inflammatory and allergic processes. This is non-specific action that is useful for any type of stress. If central nervous system operates faster, if there are more energy, and unnecessary reactions, inflammation and allergy are suppressed. So it can be helpful in any case. So we say that stress activates the so-called hypothalamus, pituitary, adrenal axis, the whole axis. CRH, ACTH, cortisol secretion. And hypothalamic pituitary adrenal axis results finally in elevated secretion of cortisol. And cortisol effects provide increased resistance to various stress factors. So stress can be different in type and may have some specific characteristics, but this is non-specific change that is induced by many different types of stress factors. And cortisol is helpful in these cases. Then let's shift to the therapeutic usage of glucocorticoids. There are numerous synthetic glucocorticoids that are used widely, such as dexamethasone, methylprednisolone, and they all bind to the same, produce the same reaction similar to cortisol. So, primarily, they are used for their anti-inflammatory, anti-allergic, and immunosuppressive effects. So, intensive inflammatory processes can be treated by this. Allergy can be treated. And autoimmune diseases, this is perhaps the widest area where corticosteroids are applied. Immunosuppression is necessary for unnecessary autoimmune reactions. And there are many points of this action. Inhibition of phospholipase A2, I believe that you remember already. But not only. Interleukin-2 production also is suppressed. Proliferation of T lymphocytes is suppressed. And this does not require great explanation because if you recall the first effect, protein catabolism in many tissues, including lymphoid tissue. So if there is protein catabolism, T lymphocytes cannot proliferate. Proliferate is to develop numerously, but it's suppressed greatly because of catabolism of proteins. So T lymphocytes are suppressed, and histamine and serotonin release from mast cells, from tissue basophils, is also suppressed. So it contributes to decrease of allergy intensity, and also it decreases capillary wall permeability. Maybe somehow specifically, maybe through decreased production of cytokines, but there is a serious stabilization of capillary walls, and if you remember, lysosomal membranes as well. So all this action helps in many types of diseases. And here you should understand that very often corticosteroids are used in very high doses. Here now you can observe normal hypothalamus, pituitary, adrenal axis, when normal cortisol produces its normal biological action and by negative feedback keeps normal CRH and ACTH. Now let's observe what may happen in case of high doses of hormones, and they can be used for very, very long time. For example, such diseases as acute glomerulonephritis, autoimmune disease, can be treated with 8 months or even more. Some rheumatic fever, rheumatic arthritis. These diseases, autoimmune diseases in their nature, should be treated for months or up to a year by high doses. And clearly, the negative feedback regulation is affected in this case. Look, first, exogenous corticosteroids of supraphysiological levels. They produce their biological action and even therapeutic action, anti-inflammatory, immunosuppressive action. But similarly to normal cortisol, they suppress pituitary secretion and hypothalamic secretion. So there is no CRH, no ACTH practically at all. Of course, doesn't occur immediately, it takes time. But you see here is mentioned, a little bit more than 3 weeks is already enough, while treatment may last for months. So long-term treatment with high doses of synthetic corticosteroids simply suppresses secretion of CRH and ACTH and own adrenal gland adrenal cortex of the patient, its zona fasciculata becomes almost disappearing, atrophied zona fasciculata. So, and here it's important to understand that the treatment cannot be stopped abruptly. So when treatment is already finished, we expect that sufficiently and successfully autoimmune antibodies are suppressed, and so the treatment does not stop immediately, abruptly, and it decreases gradually within weeks in dose, so that negative feedback gradually enables to restore normal CRH and ACTH secretion. And when treatment is totally stopped, then the own cortisol can be produced by patient. Of course, during this long-term treatment, excess of synthetic glucocorticoids produces effect actually similar to excess of cortisol, and many symptoms of the excess of cortisol cannot be prevented, and they appear in patients, but it's less bad as compared to disease itself. And finally, after treatment is over, all this or almost all can be reversed. Let's now observe symptoms of the excessive secretion of glucocorticoids, and it's called Cushing syndrome. Cushing syndrome. I explain later who is Cushing. First, he described it as a disease, but they are similar in many cases. So, first, mostly we can more or less logically deduce the increased effects of normal cortisol action. We can deduce some resulting symptoms, or explain at least. Let's start. You remember that effect on protein is catabolism, and in number of tissues: muscle, bone, skin, mucous membranes, and lymphoid tissue. So for muscle, if we every day have normal cortisol level, and every day little amount of proteins is catabolized in muscle, our muscles do not have any problems in functioning, they do not become damaged anyway. But long-term increase of cortisol produces finally serious catabolism of proteins in a muscle. So muscle become smaller even in size, muscle wasting, and they become very weak. So this is classical resulting symptom. Then bone. Due to long-term excess of cortisol, bone become very fragile and become fractured easily due to osteoporosis, rarefining of structure of bones. In the skin, catabolism of protein in the skin results in skin thinness. Skin becomes very thin and not much elastic, and it can, especially the subcutaneous part of skin, deeper layers of skin, can be even ruptured, while more elastic epidermis remains not ruptured. And so through epidermis, which becomes extremely thin and practically transparent, like a little, like paper transparent, and these pores appear, that lines, fissures of rupture. Through this we can see the vessels beneath. But which vessels can be seen? Capillaries are microscopic, arterioles are much smaller, and venules are largest vessels that can be visible through these rupture areas. And venules do have the venous colors of blood, so it becomes dark purple, dark red, dark purple. And these stripes are called in Latin striae. Striae appears of the dark purple color and easily visible. They are greatly different from such stretch marks that can appear, for example, in abdominal area in pregnant women. With normal skin, they become not much visible and much paler, and because the upper layers of skin are not so much wasted by the protein catabolism, so they be pale and become progressively less and less visible, while striae become very much visible. Then mucous membranes. You know that digestive tract mucous membranes have the fastest exchange of cells. All the cells become simply removed from the surface and should be replaced by new and new very, very quickly. And taking into account that there is protein catabolism, you may understand that this process is greatly damaged. And the protective function of mucous membranes can be lost, and easily ulcers of digestive tract or simply damage of digestive tract mucosa can develop. Then lymphoid tissue protein catabolism causes suppression of immunity. while normal cortisol level just keeps lymphoid tissue normal and lymphocytes maintain normal amount of lymphocytes, then in excess it produces serious suppression of immunity. And next move to the function, also poor wound healing. Actually, for any healing we need to have formation of proteins. Не могу говорить. So we need for healing the process of protein formation, and protein catabolism prevents from normal healing. Then let's move to the glucose level. The number one effect of glucocorticoids, even fixed in the name of these hormones. High glucose creates hypoglycemia and stimulates insulin secretion. And insulin secretion itself becomes not much effective in glucose decrease, but it becomes more effective in a process that also is stimulated by insulin. Insulin stimulates formation of fat, and this fat is deposited somehow specifically in case of excess of glucocorticoids. It's called the central obesity. Still, a very logical explanation is not found yet. Why only the upper part of the trunk and face and neck area makes maximal fat deposition, but symptoms are clear. Round face, which is called moon face, the symptom official name, deposition of fat around the neck and on the posterior part of the neck and upper portion of the back, buffalo hump forms the so-called buffalo hump, specific type of obesity. Especially it's expressed on the background of very thin extremities because of muscle wasting. So central obesity, specific type of fat deposition predominantly for upper part of the body. It's mainly because of insulin secretion. Then contra-insular action, that the hormones make problem for insulin quick and efficient decrease of glucose. Finally, may destroy for long-term cortisol excess, may destroy the whole regulation of glucose, and the so-called steroid diabetes, secondary diabetes, may develop in patients. It very often develops. Then, permissive effect that increases adrenergic receptor sensitivity, creates hypertension in people because of high cardiac output and high vasoconstriction, and therefore blood pressure usually is increased in these patients. And all this listed is included into the description of the Cushing's syndrome. The first who described this was American neurosurgeon Cushing, and actually he described the Cushing's disease. It even received the name, his name, Cushing's disease. In 1912, he described this Cushing disease. The symptoms are the same, just there is a little difference. But before consideration of this difference, let's observe the symptoms again as the pictures. The true photos sometimes are so scary, so I prefer to show you the schematic presentation with little addition of pictures. Moon face. Of course, picture does not show exactly. Look at like this. Of course, it depends on the severity of the disease, but the most pronounced symptoms really look severe. And after treatment, the same woman has normal face without any additional fat deposition. This is the same person after treatment. Then, buffalo hump can be visible on the skin, but this is an example. The specific fat deposition behind beneath the neck, on the posterior, on the back. And then, purple stria. You see they are bright in color. Some pictures are even worse, but I didn't want to show you this. But they are clearly different from the stretch marks of normal, healthy skin. Obesity develops even in treated patients who, due to treatment, it develops. It's hard to prevent. Then high blood pressure, thin skin, easy bruising, osteoporosis, muscle weakness, ulcers, and so on. This full list of symptoms. And also it's necessary to keep in memory that cortisol has little addition of mineralocorticoid effects similar to aldosterone, but excessive cortisol can really provide enough these mineralocorticoid effects, which mostly are fluid retention in the body, decreased potassium, and alkalosis. But we are going to consider this excess of aldosterone in detail. So, glucocorticoids excess. Now let's compare two cases, primary and secondary excess. Primary hypercorticism. You also can find the term hypercortisolism. Hypercortisolism or hypercorticism. I chosen the shorter one, but because both can be used. And primary hypercorticism is exactly Cushing's syndrome, not disease. But symptoms again are similar. In both cases there is excess of cortisol, but primary excess is because of problem with adrenal gland. Usually this is the oversecretion of cortisol due to tumor of the adrenal cortex itself. So excess of cortisol contains the secret and produces all its effect. And simultaneously we have, by negative feedback, great inhibition of these hormones. Both CRH and ACTH are greatly inhibited. So when blood level of hormones is checked, we can see cortisol is increased and simultaneously ACTH and CRH are decreased. And all symptoms of cortisol excess are present. Then, second case, secondary hypercorticism or hypercortisolism. This is Cushing's disease. This is exactly what Cushing described in 1912 first. And here, this is secondary. So, cortisol is produced by healthy adrenal gland, but this healthy adrenal cortex simply is overstimulated by excess of ACTH. And here there is a tumor of the anterior pituitary. Anterior pituitary, the so-called basophilic adenoma. Adenoma consisting of cells, basophilic cells, that produce ACTH. And so this is excessive ACTH constantly stimulates the fasciculate zone of adrenal cortex, and fasciculate zone becomes hypertrophied and produces excess of hormone, secondary excess. And now negative feedback doesn't operate because tumor is uncontrollable. Doesn't matter that cortisol level is high, tumor continuously produces excess of ACTH. And then there's a difference that cortisol is high and ACTH is also high. And as difference is not in cortisol, but difference between two primary and secondary cases is only ACTH presence for Cushing's disease, there appear some additional symptoms of ACTH excess. And let's observe these additional symptoms. All described before symptoms present in Cushing's disease, plus ACTH excess. First, ACTH, if you remember, has effect of stimulation of the fasciculate zone to produce more cortisol, but this is expressed as excess of cortisol. Then a little bit it stimulates also reticular zone to produce more androgens, and it makes already a difference. And plus ACTH has few own effects, and some effects simply coincide with action of cortisol. For example, increase of glucose. Just ACTH stimulates glycogenolysis, but finally glucose is increased, and so it may contribute to diabetes formation and so on. Then there is effect of stimulation of melanin production in cell, because ACTH operates instead of melanostimulating hormone. It performs the function of melanostimulating hormone. And when ACTH is normal, synthesis of melanin in skin cells is normal, but excess of ACTH and long-term excess produces hyperpigmentation. So more melanin is produced in skin cells. Not necessarily evenly throughout the body, sometimes in some areas mostly, but hyperpigmentation often develops in case of ACTH excess, which is characteristic for the secondary hypercorticism or Cushing's disease. And also, for women, it makes a big difference because more androgens produced change the female into the side of virilization. Virilization is a masculinization. So some men secondary characteristics may appear, and lower voice, growing beard, changes of shape of the body according to male, and so on. These are additional symptoms that are present in Cushing's disease in comparison with Cushing's syndrome. Insufficiency. What happens if glucocorticoids are insufficient? In most cases, glucocorticoids insufficiency develops as a total insufficiency of the adrenal cortex. But let's consider glucocorticoids insufficiency only. First, it's a decreased stress resistance of the body. There is no elevation of cortisol that provides normal resistance. And people easily may have some great decreases in health due to some harmful action. Then decreased blood pressure, hypotension, due to decreased sensitivity to catecholamines, due to absence of the permissive effects. Then hypoglycemia, because glucocorticoids contribute to higher glucose, and there is no this effect, so glucose is decreased. Muscle weakness, which partially because of decreased glucose, partially because of inability of cells to use glucose even in the presence. Then lymphocytosis. There is no normal effect of suppression of lymphoid tissue proliferation. There is no limitation for lymphocytes formation, so lymphocytosis develops. And in case of primary cortisol insufficiency due to negative feedback, deficiency of cortisol does not inhibit ACTH, and ACTH becomes high and hyperpigmentation appears, and they are the symptoms of excess of ACTH. These are insufficiency of glucocorticoids symptoms. And now we come to the superficial layer of adrenal cortex, the glomerulus zone, where aldosterone is produced. And it's produced by activation of renin-angiotensin-aldosterone system. It's a very well known RAAS system. As you can see in this system, before aldosterone, the angiotensin comes, and so it's an immediate factor that stimulates aldosterone. But the whole system starts from renin secretion, whole system activation. And renin is secreted when renal blood supply decreases, which can happen when blood volume total and total blood pressure becomes greatly decreased, and so renal blood supply decreases. Aldosterone effects are not so multiple as compared to previously described hormones and can be listed in few lines. And if you remember that it's mineral corticoids, you will not start to consider about metabolic effects such as influence on protein, fats, and carbohydrate metabolism. No, main minerals, main ions of the body are influenced by aldosterone. And these effects mostly are achieved in kidney. This is sodium reabsorption. Sodium reabsorption produces as a result reabsorption of water, because sodium is #1 osmotically active substance, and when sodium ions are reabsorbed, taken from tubules back into interstitium and remain in the body, extracellular fluid, each ion takes along molecules of water, and so water reabsorption goes proportionally normally to the sodium reabsorption. And perhaps it's #1 effect, because if we manage to reabsorb sodium, we can keep corresponding amount of water in the extracellular space. And so it helps to maintain normal volume of the extracellular fluid, therefore the part of this volume which is blood volume and correspondingly blood pressure. So all effects can be deduced from this. But not only sodium is affected, because sodium is reabsorbed in exchange to potassium. So while sodium goes and remains in the body, potassium goes to the lumen of kidney tubules and is lost from the body. So it contributes to renal secretion, decreased reabsorption, so it's renal secretion. It's not endocrine secretion, don't mix, it's renal secretion, which means simply release into tubules. Potassium is released into tubules, and so it decreased in blood. And also in some other cells, hydrogen ions are removed into lumen and lost from the body. So aldosterone contributes to increase of sodium, decrease of potassium and hydrogen due to renal processes. And angiotensin is main stimulating factor for secretion of aldosterone, and also ions changes can produce it, but mostly higher potassium level stimulates secretion of aldosterone. And if you remember, ACTH does not stimulate but must be present to provide the first step of conversion of cholesterol into pregnenolone, so that not only aldosterone but all steroid hormones of adrenal cortex can be formed. Symptoms of excessive and insufficient aldosterone secretion can be easily deduced from normal effects of hormone. Hyperaldosteronism, excess of aldosterone, usually it's the Cone syndrome, and it can be caused by tumor that secretes aldosterone. There are some tumors that secrete aldosterone, and so excess of hormone occurs. And so you can see, first, excessive sodium reabsorption, and correspondingly water reabsorption is higher than normal. So blood volume increases and hypertension, blood pressure increases. So hypertension due to sodium and water excess. As for second effect on potassium, hypokalemia develops, decreased potassium in blood, because potassium is lost from the body. Proportionally, the more sodium remains in the body, the more potassium is lost. And decreased potassium hypokalemia results in muscle weakness, decreased heart contractility, and some other changes. And last, influence on hydrogen. Excessive loss of hydrogen brings shift to the balance to the side of alkalosis, metabolic alkalosis, due to loss of hydrogen. And finally, everything is opposite in case of aldosterone insufficiency. For example, this is Addison's disease. Addison's disease is usually total adrenocortical insufficiency due to some damaging factors, or sometimes it's hard even to know the reason, but the secretion of hormones is greatly suppressed. So, among all the hormones of the adrenal cortex, actually aldosterone is vitally essential for life. Of course, glucocorticoids also are important, but people with decreased glucocorticoids will be suffering but not dead very soon. But with aldosterone deficiency, just usually in a few days death may come, or a little bit longer but not much. Because sodium is necessary to keep in the body, because sodium keeps water. Loss of water means loss of extracellular fluid volume, which means in turn blood volume loss and decreased blood pressure. When all these parameters fall lower the critical level, it results in not enough blood supply to brain, loss of consciousness, finally coma and death. So hypotension clearly develops due to loss of sodium and water, and it decreases extracellular fluid volume and blood volume. Then, for potassium, opposite, it will be hyperkalemia, excess of potassium, because the less sodium is lost, the more potassium remains not excreted from the body. And hyperkalemia produces cardiac arrhythmias, and you see the same that was mentioned to the left side, muscle weakness. The influence of potassium on the body is very complex, and sometimes even some points are the same. And finally, for influence on hydrogen. Potassium excess and hydrogen excess is achieved because of less secretion of hydrogen into lumens of tubules. So metabolic acidosis develops. So excess of hydrogen. So everything is simply opposite. And now we considered main hormones of adrenal cortex and the thyroid hormones. And thank you for your attention. In the second part, some other hormones consideration is expected.